Hello and welcome to this e-module on vulnerable populations. I'm Mathavi Senguttuvan, a researcher with the National University of Singapore's Centre for Biomedical Ethics, and I will be taking us through vulnerability as a concept and its importance in healthcare provision, in hopes of expanding how we understand and apply the concept beyond layperson terms, labels, or categories. We hope that at the end of this course, you will be able to better understand the concept of vulnerability, which could in turn result in better appreciating and situating the concept as a fundamental aspect of healthcare practice. To this end, we will review various ethical and legal frameworks, especially within bioethics, which dynamically approach vulnerability and vulnerable populations. With the help of specifically designed vignettes, you will be able to better understand how to appropriately and carefully recognize vulnerabilities in patients in the context of care provision, without inadvertently participating in stereotypes or potentially stigmatizing certain groups. Now, these are the three broad segments of the course, and we will be covering them through three short videos as indicated. So first, what is vulnerability and how has it been conceptualized? Now, do bear with me because this segment of the module is going to be a bit theoretical, but I'm hoping that it will help us engage with the concept in a more comprehensive manner beyond the conventional confines within which a generalized or lay understanding arises. That is, certain population groups are simply vulnerable because they are who they are, or because they feature some kind of undesirable attributes that necessitate protection from possible harms. Now take a look at all of these terms and concepts. For the purposes of this module, let us zoom in on vulnerability as the focal point at which all these other terms or concepts converge. We can see that there may be an underlying thread that links many of these terms to an overarching susceptibility to harms. And these harms could be exploitation, discrimination, or even physical violence. And perhaps because they bear traits that are characterized, often inappropriately so, as limiting or weaknesses, such as physical or intellectual disabilities. Or some groups just instinctively come to mind, like children due to their young age and developing cognitive abilities, which render them more susceptible to these harms. We end up searching for criteria based on which to include or exclude groups of people from the application of the concept, because it helps us identify those in need of protection or support in times of crisis or when these harms are about to occur. But these criteria may not always be accurate, or they may sometimes exacerbate the wrongs when applied indefinitely or to groups as a whole. At the same time, not engaging in the process at all could actually mean many being neglected and not receiving the care that they need. And this is what makes vulnerability such a debated yet pervasive concept. It suffers from simultaneous oversimplification and overcomplication. There isn't yet any one universally accepted conception of vulnerability, but we will try to lay out some of the broad ways of understanding the concept in this video and hopefully provide more clarity on how to navigate this complex concept. The term vulnerability is derived from the Latin terms vulnere or vulnus, which relate to wound or wounding. General references to the term could indicate increased exposure to the risk of suffering losses or damages, or being harmed, wounded, or attacked physically, emotionally, or cognitively. Within healthcare and bioethics specifically, we see that the concept finds its origins in research ethics, especially as a concerted response to significant instances of ethical and legal violations in scientific research conducted during the Nazi regime or the Tuskegee syphilis trial in the US. But more on this in the next video. On a more conceptual note, two broad approaches have been identified based on reviews of various theories and literature pertaining to vulnerability, namely ontological or inherent vulnerability and situational or circumstantial vulnerability. Now, these approaches may have further subsets. In particular, certain situational vulnerabilities have been identified as arising from pathogenic sources or a sort of cascading effect of pre-existing vulnerabilities being aggravated or new versions being created by harmful situations or relationships. This is actually an important contribution which stems from feminist approaches to bioethics. Now, as the title suggests, universal or ontological references to vulnerability look at the very condition of human existence, a shared, fragile, and vulnerable existence. Notable amongst several different conceptions of this type is Martha Feynman's conception of vulnerability, which stems from feminist legal theory and focuses largely on the state's responsibilities towards its vulnerable subjects. Here, vulnerability is a universal, inevitable, and enduring aspect of the human condition, one that actually unites us across differences and calls for solidaristic action. This approach to vulnerability rejects the notion of invulnerability as a norm. That is, that persons who illustrate certain characteristics deserve special attention solely due to their so-called weaknesses. This rather commonly accepted notion actually fails to recognize that we're all vulnerable because we are embodied beings, necessarily dependent on and embedded within various social relationships and institutions. After all, we are or were all children once, and we are or will all be old and frail at some point. We've all been, are, or potentially will be caregivers, and we all have or will potentially require care at some point. These characteristics remain inherent to the human condition. Now, a shared universal notion of vulnerability like this may negate the stigmatizing effect of being labeled vulnerable and reimagine the narrative of being vulnerable as commonplace. But having said all of this, a generic universal notion could raise some eyebrows. A few questions to think about. Are all humans truly vulnerable in the same sense? Aren't some more vulnerable than others? Also, could this happen to minimize the struggles of people whose experiences others can never access? And finally, if everyone is vulnerable, do we really need this concept? How can we effectively employ the concept to aid certain groups of people who obviously may require more attention than others? On the other hand, we have certain approaches to vulnerability which specifically look at certain contexts and factors that may influence how certain people should be considered vulnerable. Now, there are various terms such as situational, circumstantial, contextual, conditional, and these are often used interchangeably to describe this broad type of vulnerability. Under this approach, specific individuals or groups are therefore considered vulnerable due to circumstantial properties or conditional factors that are add-ons to the inherent traits. Some examples could include economic factors, social-cultural factors, educational factors or limitations, for instance, political factors, physical or intellectual factors. And these factors may each on their own or together or in combinations of each other render these persons either incapable of making decisions in their own interests and or susceptible to losses, damages, exploitation, discrimination, and other types of wrongs. In fact, most practical or applied approaches to vulnerability tend to fall under this type, since there is usually one common objective, which is to identify the defining traits or circumstances which can render certain people vulnerable. And these broad types are not mutually exclusive. Many approaches to defining vulnerability start with the recognition of its ontological or inherent dimensions and follow up with specification. For example, elderly persons can be considered inherently vulnerable as aging is part and parcel of the human condition. Take 70-year-old Mrs. Stay, for instance. She struggles with Alzheimer's disease, and she lives all by herself since her children have moved out and her husband has passed on. She is also situationally vulnerable to the adverse implications of loneliness, inadequate care, etc., due to these compounding circumstances. The problem with this type of vulnerability is that it creates certain categories and labels. It tells us that certain people would always be vulnerable due to these factors that are characteristic of their existence. And this could lead to stigmatization or marginalization, as we have already discussed. Effectively, we can see that there are 4 commonly understood approaches. The philosophical or ontological approaches we've just discussed, that is, what it means to actually be human and what it means to be vulnerable as a human being. Then we have the labeling approach, and this is the conventional approach in healthcare practice and research. The aim of this approach is to categorize, label, and classify vulnerable persons who may require special attention through group membership, because that just makes it easier. Under the analytical approach, the focus is on sources, reasons, and consequences, rather than identifiable populations. And these sources or reasons and consequences are centered around specific risks such as abuse, exploitation, violation of autonomy, etc. And the focus is on listing these specific risks so that we can know which population to actually look at. And then we have social sciences approaches, which could be political, economic, sociocultural, etc. And there are various manifestations of these forms of vulnerabilities or these approaches to vulnerabilities, and they are contingent on largely extrinsic circumstances. Now, I'm not going to go into vulnerability during crisis situations such as disasters or economic instability in this module, but I'm going to be focusing on the health-specific aspects, although these reasons could broadly apply to the crisis situations as well. So before we proceed to discussing some of the practical approaches to vulnerability, let's discuss some common criticisms of the concept. Some have called it too vague or too broad. If everyone is vulnerable, then who should be entitled to special protection? What is the point of the concept? Do we really need it? On the other hand, some accounts are critiqued for being too narrow and actually reductivist. For instance, if we take the idea of listing or labeling certain types of vulnerabilities, we have the immediate consequence of considering certain approaches inadequate or stigmatizing and unfair. It could lead to mislabeling or characterization, which is usually directed at labeling approaches or those that are strictly focused on capacity to provide consent or strictly focused on protection from harm and abuse, etc. As a result of all this, we have stigmatization or marginalization of these specific groups that have been labeled. And further, we have exacerbation of vulnerabilities or creation of whole new victims. Some have called to replace the concept altogether with other concepts such as marginalization, which could more clearly delineate and identify groups who would require special attention. Often, the concept has been considered coterminous with paternalism, because more often than not, the goal behind identifying these population groups is to protect them from harm. And there have been calls to have an attitudinal shift about this. We find that how the law approaches vulnerability is often mired in these very criticisms. So let us look at some bioethical approaches to vulnerability. These are often less conventional than those that we've discussed so far, and they've been identified in the bioethics space more generally, and also within specific domains of bioethics, like research ethics, public health ethics, clinical ethics, etc. In research ethics, for example, traditionally, we have two main reasons for including vulnerability as a concept in research. One is respect for person space. When certain people lack capacity to provide informed consent to research, these people have to be protected from the potential pitfalls of participating in research. Two, we have justice-based reasons. Certain people are simply unfairly positioned. They're exposed to injustices due to exclusion or exploitation. Some approaches include listing sources of vulnerabilities rather than population groups as a whole. These sources could be medical, cognitive, infrastructural, etc. Another approach, which is actually generic to bioethics, is the layers not labels account. Luna, in fact, suggested that vulnerabilities can be layered on top of each other or against each other, and people can be vulnerable to multiple things at the same time. On a broader scale, in public health ethics, vulnerable populations are those who are at increased risk of adverse health outcomes. They can be medical, that is by illness or ailment, or they can be social, that is by way of being a part of disadvantaged groups. Identification by group membership is considered necessary in order to prevent these outcomes before they manifest, even at the risk of stigmatization and discrimination. Thanks to some of these approaches within public health ethics, there is increasing conceptual focus on social justice. The idea that exposure to risk of harms or losses due to unfair or unjust positioning is likely due to imbalanced relationships or power dynamics. And the idea behind these approaches towards social justice is to balance these relationships or reduce the impact of power dynamics. Within clinical ethics specifically, the conceptual accounts are limited. Healthcare professionals' preference seems to be for intuitive group labeling. They may be due to biological causes such as illness or pain, or contextual factors such as poverty or illiteracy. Samia Hest in 2008 explored a diagnosis account. This is a more general account where we look at the increased likelihood of wrongdoing rather than, say, specific factors such as harm or biological or contextual factors. But generally, in clinical ethics, the conceptualization of vulnerability must be extrapolated from established principles such as respect for autonomy, beneficence, etc., which seek to protect patients who may be vulnerable to abuse, harms, exploitation, etc. And thus, we need to provide special attention to reduce those vulnerabilities. Another approach that is common is the decisional approach, that is, where informed consent is required towards respecting patients' autonomy. And this decreases this vulnerability to being unduly influenced in the decision-making process. However, those who lack capacity to consent are often pulled into an especially vulnerable group who require special protections, such as the best interest principle. But this approach often fails to avoid discrimination or exclusion of incapacitated persons as a group and maintains paternalistic undertones. Now, based on all of these approaches, these theoretical conceptions, we have obvious problems with knowing what vulnerability means. We have difficulty identifying who, why, and how certain people should be considered vulnerable. Often, the law enters the picture to provide solutions, but we are unsure if these are actually sufficient to answer these problems. So in the next video, we will look into exactly how the law and legal frameworks deal with vulnerability and respond to vulnerable populations' needs. Thank you.